Surgical pearls in Phakic IOL for beginners. Phakic IOL is an intraocular lens which implanted in addition to the natural crystalline lens to correct the refractive error. It's a surgical procedure that offers a valuable alternative for patients ineligible for traditional cornea-based refractive surgery. While the surgery itself is relatively straightforward and within the skill set of most cataract surgeons, what presents a challenge for novice surgeon is the minimal space available, which is hardly 3 millimeters of anterior chamber depth to execute all the necessary steps. So here are some tips and tricks which will make phakic IOL implantation easy. So let's learn about designs and the correct way of loading phakic IOLs. Implantable collamer lens or ICL by Star Surgicals. It has one central port for aqueous flow, two ports on the side and two on the haptics. The direction of the lens is identified with the port on the right leading and left trailing haptic. The Star Toric ICL has two different markings other than the ports on the side for axis. The Hyperopic ICL has no central port to avoid aberrations as this IOL is thicker in the center and hence it is necessary to do surgical PI with Hyperopic ICL. Loading ICL. Hydrate the cartridge with BSS. Fill nozzle with HPMC viscoelastic. Remove ICL from the vial using plunger. Insert ICL into cartridge bag with the port at right leading and left trailing haptic. Grasp the ICL using forceps from the nozzle side. Withdraw cartridge very slowly without pulling the ICL. Make sure ICL is well centered, that is 3 ports on the optic are in the same line while looking from above. Engage cartridge into the injector from the front and make sure ICL advances easily by pushing plunger slowly. IPCL by Care Group. Apart from central port, it has 6 ports in optic and 4 ports in haptic. Direction of IPCL is decided by 2 paracentral ports which will face upper lid, and out of 4 ports on haptic, 2 heart-shaped ports will be on left leading and right trailing haptic and 2 side bumps on left leading and right trailing side. Loading is like any other foldable IOL. Make sure the direction of the ports are as mentioned earlier. iCryl by Biotech. It has one central port, 2 ports on side and only 2 ports in haptic. Direction of this IOL is derived by ports in left leading and right trailing haptics. Loading is similar to any other foldable IOL. Ensure that the direction of the ports is as mentioned earlier. Note that iCryl Phakic Toric IOL has axis markings which are not in line with the 3 ports on the optic. Tips for making ports. Make sure that all the ports are parallel to iris plane. Ports not parallel to iris plane can cause damage to either cornea or the crystalline lens. Make controlled entry to protect the lens. Tips for injecting viscoelastic substance. Use dispersive HPMC OVD which will protect endothelium and will make space to perform surgical steps. Inject OVD only till noodle phase and do not overfill. Overfilling can push iris backwards, making it difficult to tuck the haptics of ICL behind the iris. Tips for implantation under viscoelastic. After filling the globe with OVD, engage second instrument in the side port to stabilize the globe and to maintain anterior chamber. Keep an eye on ports of the ICL to ensure correct direction of the ICL. Inject slowly to avoid any trauma to the lens or cornea. Once you have mastered implantation under visco, you can advance to hydroimplantation. Engage one port with a hydrocannula and inject the ICL with the other hand. This technique offers advantages such as avoiding OVD related complications and saving time during the procedure. Tips for tucking haptics. Do not inject the ICL directly in sulcus. Inject it in anterior chamber. Tuck 2 haptics on one side under the iris and then the other 2. Hold the haptics at the corners. Ensure to not touch optic during this step. For the toric ICL, inject the ICL in such a way that ICL markings are aligned close to the desired markings on the cornea. Rotate the ICL after tucking the haptics. Make sure not to touch optic while rotating the ICL. While irrigation and aspiration, hold the irrigation and aspiration cannula alternatingly near the central port to remove OVD from behind the ICL. For hyperopic ICL, there is no central port, so make surgical peripheral iridotomy with 23 gauge vitrectomy cutter to ensure free aqueous flow. Even after taking all the surgical precautions, complications are bound to happen. So let's take a look at how to tackle these common problems. What if the phakic IOL gets stuck while injecting? Rotate the injector while injecting to ensure the IOL goes in the right direction. Pull the plunger back to free the stuck haptic and then push it again. What if the phakic IOL is not advancing smoothly in the injector? In such cases, it's best not to struggle and abort the mission. Check the injector to locate the stuck haptic. Try injecting the ICL back into the bottle or gently free the stuck haptic using blunt forceps. Reload the ICL and attempt injecting it again, ensuring smooth advancement this time. What if the phakic IOL gets stuck in the main port while doing wound assisted delivery? Check the alignment of the phakic IOL using the direction of the haptic ports. If the alignment is correct, cautiously slide it in with blunt forceps. Ensure not to predispose the main port to Descemet detachment. Be gentle to avoid damaging the IOL. What if the phakic IOL gets twisted while injecting? If noticed in the early phase, do not inject the IOL completely. Explant the IOL using forceps. Do not pull the IOL forcibly as these are very delicate and there are chances of tearing the IOL. These are custom made and no standby lens will be available in case of damage. Reload the lens again, check its proper alignment and inject it again. What if I notice the phakic IOL is twisted while injecting? While injecting the phakic IOL, support it with a second instrument to prevent it from completely flipping. Once injected completely, bimanually maneuver it in the right direction. What if I realize that the IOL is flipped after delivering it completely? Create space to maneuver the IOL by injecting OVD behind and in front of the IOL. Use bimanual manipulation to flip the IOL in the anterior chamber, ensuring its correct alignment. Throughout the process, prioritize the protection of cornea and the lens. If necessary, inject OVD in between to maintain the space and facilitate safe manipulation. With new advancements, it is possible to check the vault intraoperatively using OCT. In cases of extremely high or very low vault, we can explant the ICL and implant the correct size in the same or different setting. Refractive surgery is a rapidly evolving and high demanding field. By these simple tips and techniques and promptly addressing any complications that may arise, beginner surgeons can significantly elevate the safety and effectiveness of phakic IOL implantation procedures. Thank you.